going to start with, you need to go through your didactic curriculum and identify all the courses that will come up, cases you might see in that particular rotation. Review them. You have to do that. One whole week, review them. If you don't have flashcards, develop the flashcard now. Carry it with you. 2 weeks into that rotation, you would have seen more than 50 to 75% of what you're going to see. Medicine is so repetitive, especially if you're there every day. About the third week, you're done with that rotation. You're preparing for your next rotation. And that Monday, I made your end of rotation now 1 whole week. I gave you a whole day to prepare for that end of rotation exam, right? That 1 day is when you now go back to what you've seen and what you prepared, what you read before the rotation to prepare for your end of rotation exam. Don't allow your fear of preparation for your end of rotation exam to take time away from your study that you need to do the preparation for that next rotation. Because believe you me, it goes by like that. And you go through it not knowing anything unless you're able to relate what you're seeing on day-to-day basis to what you already knew in class. That is the only way you're going to seal that in your mind. The eyes and the mind are powerful. You need to see these cases. There are some cases, and you have some good rotations now. I've met some of your preceptors, great people that will teach you tremendous stuff, and very busy places. You will see a lot. But if you cannot, see, the truth is, the eyes, they recognize only what the mind knows. So it does not matter how long I put you in a clinic. If your mind is not ready, you will not recognize what you're seeing. It will make sense. But if you prepare your mind, then whatever you see in your clinical year, you will recognize it. It becomes part of you. You don't forget. If you ever seen a car run over somebody, you don't forget that. So it is just like that. Your clinical year is going to be as helpful as much as you prepare for each of those rotations. By the time, if you do what I just told you, by the time you finish, you can't wait to get out of here. Because you'll be so anxious to get out there and do stuff because you feel you know so much and you're carrying it with you. Your residual knowledge, which is what you need in practice, will be so high. Because in practice, you don't have time to go start looking for every patient. You only have 10-15 minutes. You're going to work with your residual. And the only time to develop that is during your clinical year. Okay? Please remember what I just said. Right, well, let's talk about metabolic bone diseases. Maybe you know, I don't know. Bones undergo remodeling all year round. Okay? So, bone is constantly being taken up and being laid down. Right? We call it bone remodeling. The cells that chew the bone out are called osteoclasts. The ones that lay it down are called osteoblasts. If everything goes well, if you come back to this classroom in 10 years, the carpet should be different. Yeah, because we'll remove the carpet and we'll relay one, just like you do in your home. You're constantly remodeling stuff, right? So the bones undergo exactly the same thing. All right? I want you to kind of know that, and under normal circumstances, the rate at which bone is formed is equal to the rate at which it is being resolved. So that the structure of the bone and the strength of the bone is not affected by the remodeling. Okay? And there is this compound called receptor activator of nuclear factor carboxylase. Call it RANKL. You don't need to know any more about it than that. Just know it does exist. And this RANKL ligand is the pivotal regulator of osteoclastic activity. That is important. The reason it's important is that there is osteoclastic activity and there is osteoblastic activity. But what the body regulates is the osteoclastic activity. You got that? Okay. There is no major regulator for osteoplastic, because osteoplastic is good. It's always good for building. What you want to watch is the destruction. You want to monitor the destruction. You don't want people coming to rip off the carpet in your home before you're ready to replace it, right? Okay, so that is why it's good to regulate osteoplastic activity, and osteoplastic activity just follows, right? Even when you don't, we all buy things we don't need sometimes just because we like them, right? So there is no need to, and there's nothing wrong with buying stuff. What you don't want is somebody taking your TV before you're ready to replace it, right? So osteoclastic activity is what is regulated, and the ligand that does it is the rankle ligand. Okay, good. How is bone mineralization regulated? This diagram looks very, very complicated and confusing. You don't need to worry about it. Just read what is in that gray box. Everything else is definition. The other information is in that gray box. Fibroblast growth factor 23. Very important protein called FGF23. It is secreted by bone cells. It is stimulated by 1,25-dihydroxy-D3, parathyroid hormone, high D3 phosphate. But it is suppressed by 1-alpha-hydroxylase, it suppresses 1-alpha-hydroxylase, decreases renal phosphate resorption, and PTH secretion. That is the gist. Now, if you can understand that, now go into the diagram. So, you see the big arrow from A, high D3 phosphate stimulate FGF23, right? CPTH stimulate FGF23. C125, the arrow stimulate FGF23 by the bones, right? And FGF23 is very important in the maintenance of serum inorganic phosphate, PI, serum inorganic phosphate level, right? And then there is all kind of checks and balances. High phosphate intake gets into the bloodstream and turn on FGF23, but 125-dihydroxy-3 blocks high phosphate intake, so it blocks phosphate reabsorption, right? Look at FGF23 itself blocks PTH production, right? And then look at FGF23 effects on the kidneys and phosphate reabsorption. It blocks it. Do I need you to know all these arrows and recognize it? No. The point of this is to convey two basic information to you. Regulation of bone mineralization is complex. That's number one. Number two, three main organs are involved: the PTH, the parathyroid glands, the kidneys, and the gut. That's it. Everything else that you see here, you already know. We talked about it. You talk about it in physiology or in endocrinology. We talked about it. It's just now represented in diagrams, and I particularly chose this diagram because the image I want you to live here with is that the regulation of bone mineralization is complex. All you need to know then is that it involves major interplay between the parathyroid gland, the intestinal handling of phosphate, and the kidneys. They all work together to manage that. In terms of the specifics, you already know that. You already know PTH goes and mobilizes calcium and phosphate from bones, right? And you know the same PDH blocks phosphate reabsorption, right? So that you can get rid of the phosphate and free the calcium. You know all that. I don't need to repeat all that for you. If I was to grill you on how the kidneys handle vitamin D, you know that already. You know you're taking vitamin D in the liver, it is converted to 25-hydroxy-D. In the kidney, 1-alpha-hydroxylase is activated to convert it to 125-dihydroxy-vitamin D, which is really the active form of vitamin D, right? And you know all that that does, right? It stimulates gut, calcium resorption from the gut, right? And also from the kidney. So you know all that. So I don't want to waste time repeating myself here. If you can just remember this right here, that tells the story of all this thing that is complicated. So again, like I said, a resting bone, after a while, we'll go into this osteoclastic bone resorption phase, when the osteoclast chew it up. And then once they're done, they leave the pit, an empty space, just like moving your rod. And then the osteoblasts come and they lay the new bone, and the bone goes into resting again, and the whole cycle repeats. Mineralization disorders are disorders or imbalance in bone resorption and bone formation. Whenever bone resorption proceeds faster than bone formation, you get osteoporosis. In a normal bone resorption proceeds at exactly the same rate as bone formation. When bone resorption lags behind bone formation, you end up with excess bone. And that disease is called osteopetrosis. Okay? So let's start with osteopetrosis. Osteopetrosis is also known as marble bone disease. It's a rare disease, but somebody might ask you, right? So osteopetrosis is really a failure of bone resorption. So it's an osteoclast dysfunction. And you know what the problem is in it? The problem is carbonic anhydrase deficiency. You remember carbonic anhydrase? That enzyme that is involved in acid-base balance and even the secretion of gastric acid. Anywhere you need acid, carbonic anhydrase is involved. Anytime you have to claim a base, bicarbonate, carbonic anhydrase is involved. So the real problem with osteopetrosis is carbonic anhydrase deficiency, because in order for the osteoclast to chew the bone, they need to make acids, right? If carbonic anhydrase is not there, they can't form acid. You know how the parietal cells make acid in the stomach, right? What do? They take carbon dioxide, combine it with water, right? Form carbonic acid. With the help of carbonic anhydrase, that carbonic acid dissociates into bicarbonate and hydrogen ion, right? And what the parietal cells do is to dump the hydrogen ion into the stomach with chloride to form hydrochloric acid and dump the bicarb into blood. That is why with gastric acid secretion comes some alkalosis that is called alkaline tide. Did we talk to you about that in GI? Exactly. You have alkaline tide. And that's why every time you eat, you feel tired. Right after you eat, you feel tired because of that alkaline tide. But the good thing is that once the acid gets into the duodenum, the acidity itself now stimulates the pancreas to secrete pancreatic juice, the bulk of which is bicarbonate. Remember, so it is the bicarbonate secretion by the pancreas into the duodenum that offsets the alkalosis of alkaline tide. That's why after you rest for like 30 minutes or so, you eat, you can get up again and go do work, right? The same process. The osteoclasts make acid the same way. So when they don't have carbonic anhydrase, they are not able to put acid in the resorption pits and mobilize calcium phosphate. They can't do the work, right? So osteopetrosis was, I like the history of medicine. It's a way of honoring those that have done good things, right? So I always talk, if it is known who did it, I'll tell you, okay? So this marble bone disease was first described in 1904 by a German radiologist, by the way, Albert Schomburg. So that's why osteopetrosis is also known as Albert Schomburg disease. How does it present? Present like this. Look at that X-ray. Is that normal? So it's a dense, it looks like a strong bone. It looks like iron bone, right? But it's so brittle. So it's dense and brittle bone, okay? So they break very easily. This is is somebody you can do high five with and you break his fingers. Right? But the bones are dense and brittle. And because it's a lot of bone, there isn't a lot of marrow. And because there isn't a lot of marrow, that is why they get the hypoplastic anemia. Because remember, the bone marrow is where your red cells are formed. So if you have excess bone, that now encroaches on the marrow, so you can't form the red cells. So they get hypoplastic anemia. And because of the reduced bone mass and bone marrow, the spleen and the kidneys that used to be organs of red cell formation in ancient times, when the baby was in the womb, now get recruited to make blood cells again. So that's why you get the hepatosplenomegaly, right? It's called secondary hematopoiesis. You did that in hematology, right? Mm-hmm. Exactly. Okay. And then, of course, because the bone is constantly active, alkaline phosphatase is elevated. That is a bone enzyme. Okay. Alkaline phosphatase is found in only three places: the gut, the liver, and the bone. We'll talk about that a little bit. So you see, this is how it presents. How do we treat it? Short-term corticosteroids. Long-term, you have to do stem cell transplant. Okay, so you start the patient on steroid and you send them on to hematology oncologists, and they will do the stem cell transplant. Okay, and that's how it looks. Okay, that's all about osteoporosis. Stop. Okay, let's talk about osteoporosis. So osteoporosis is bone mass reduction and micro-architectural deterioration following an imbalance of bone formation and bone resorption. We already talked about that, right? Interestingly, this is bone mass and this is age in years. You see that your bone growth goes on until you get to your 40s. And women always start low. They grow less, they start low for some odd reason. I don't know why, but sorry guys. So see that they never get to 1500, they'll have less bone mass, right? And then everybody after 40, everything starts decreasing. You see, that is why they say a fool at 40 is a fool forever. At 40, you're supposed to be really smart and wise. Because at 40, you don't gain new information or new knowledge. Everything begins to go downhill from there. You need to be very careful about the management of the time and resources that you have accumulated before you get to 40. Because after 40, your body, you don't become stronger, you become weaker. You have to struggle to keep your strength. You know. But until then, it does not matter. You don't need to exercise now. Your bone strength will always increase. Whether or not you exercise, does not matter whether you eat chips and fries every day, your bone strength will always increase. But once you get past 40, that is no longer the case. You have to now do the right thing. Okay? So you can see how that happens right after, and how menopause does not help. Menopause even makes it worse. Alright? So it is important then for us to understand the risk factors for osteoporosis. And some of the two groups of risk factors, like we always talk in clinical medicine, there are modifiable and non-modifiable risk factors. So basically it's learning what you can help and what you have to accept, right? Age is a major risk factor, right? Over the age of 70 or older in men, 65 in women, right? Race is important. People of European and Asian ancestry have a particular unique, they have a particular disposition to osteoporosis. So they have to do it a lot more, you know. I mean, osteoporosis is rare among women of African descent, and they are more or less the least active on the planet. Okay? So, and they don't get bone loss for some reason. Nobody really knows why. Okay, but it's extremely important for you to know that. Female sex, of course, we're talking about that. Personal history of fracture. If somebody has broken the bone before, they are likely to break again, especially in their menopausal years. Family history of fracture. Their father broke a hip, they are likely to break a hip. So you pay attention to that. You know, even though it's not modifiable, you can't do anything about all this, but this can alert you to be a little bit more sensitive to that. And small stature. Small stature, of course. You know. If you're small, your bones are small. Sorry. And then dementia, because dementia is a risk factor for osteoporosis, and you can't help that. But you can help this. You can help low body weight. You can help low calcium intake. You can help cigarette smoking. Encourage people to do exercise. Don't smoke. Avoid estrogen deficiency, or androgen deficiency. You can replace all this. People shouldn't be drinking uncontrollably, right? Alcoholism is not a good thing. If you know somebody, encourage them all the time to seek help. Encourage people to be physically active. Do something. It doesn't have to be. Don't promote physical activity like it's an exercise. Physical activity does not have to be exercise. Okay? If you play table tennis, you can play table tennis every other day with your friend, your wife, your child, whatever. Just get out there and do something. If you garden and you get to shovel and do this, that is exercise. Don't make it look like if you don't have gym membership, you can't exercise. That is not true. Reality is that exercise is only in recent centuries. We are from ancestors of people that exercise every single day. And they didn't call it exercise because they hunt and they gather. Right? So don't present exercise. Whenever you present exercise like you have to do it in a formal setting, you have to have a trainer, you're creating a barrier to physical activity. Because it doesn't have to be that way. Okay? And then medical comorbidity, of course, you know about hypoparathyroidism and hypothyroidism. They increase the rate of bone turnovers. Right? Good. How does osteoporosis present? Fractures. So there is nothing a patient with osteoporosis will tell you that will tell you, oh, that is osteoporosis. No, osteoporosis is painless. You can't forget that. That's why I said porous bones are painless until broken. So osteoporosis has no symptom until they break the bone. And even then, some fractures are asymptomatic. A woman has walked into my clinic before with a broken hip. She walked into the clinic. Of course, that means it was not a complete fracture. So the neck of the femur was still intact, but it's already broken. But she just came in with hip pain. I did the x-ray from the x-ray room, in the emergency room. Right? Because the radiologist couldn't afford for her to walk again. Because if she breaks the hip right there in that place, then they're liable. Right? Okay. So it may be asymptomatic. And the common sites is the hip, the wrist, and I'm sure Katie talked about Colesman fracture, right? Okay, right? And then the spine. Okay? Alright. And when you have any of these fractures, that is when the patient's pain becomes part of the symptomatology. So osteoporosis in and of itself is a painless condition. But when the bones get broken, then pain becomes part of the picture. Right? And if it happens in the spine, guess what? You become shorter. So if your patient loses an inch and they come to you with back pain, so you have this 86-year-old female that you've known for 20 years, and she came in one day with back pain and she's 1 inch less in height. She's fractured her spine. Right? That is really hard to help. How do we diagnose it? We do dual energy absorptiometry or DEXA scan. If you're interested, I have the DEXA machine in the CTRC that can screen you. None of you need it. But just in case you're curious. So we do DEXA scan, okay? And DEXA scan is dual energy absorptiometry scan. It's basically using X-rays of 2 different wavelengths into the body, and then soft tissue and bone, they absorb it at different rates, and then they do the physics behind it. Is the rate of absorption is different for bone versus soft tissue, and then they compute the proportion of bone to tissue and the strength of the bone. At the end of the day, they give you 2 scores, a T-score or a Z-score, right? Don't get confused. T-score is like, remember teenager, okay? So a T-score compares the patient's results to a young adult. So it does not matter what your age is. Your T-score compares your bone to that of the young adult. So like a teenager, not necessarily in their teens, but generally people in their 20 to 35 years. And so I just want you to use that to remember what T-score does, right? The Z-score compares your bone strength to somebody of your age in the population. Okay? In other words, how do you compare with people that are the same age and gender with you? That is your Z-score, right? And generally speaking, you worry when it is more than 2 standard deviations, so negative 2.5, right? From the comparison group. When it is negative 1.5 to 2.4, you don't call it osteoporosis, you call it osteopenia. That is a risk factor you want to treat before the patient becomes osteoporotic, because invariably, all your osteopenic patients without intervention will progress to osteoporosis. Okay? And generally speaking, among men under the age of 50, T-scores tend to be more reliable than Z-scores. Okay? So if you're talking about men and premenopausal women, T-score may be more reliable than Z-scores. Right? But basically what I would need you to know is that both T and Z-scores are DEXA scan scores. T-scores compare the patient's numbers to that of a young adult, usually 20 to 35, and Z-scores compare the patient's bone strength and age-matched control. Okay. And then we use the same Z-score or T-score to kind of rate the severity. Like I said, if you're within 1 standard deviation, that is normal. If you're less than 1 to 2.5, that is osteopenia. Less than 2.5 is osteoporosis. If you have less than 2.5, that's more than 2 standard deviation within normal, and you're already fractured, somebody fractured, that is the severe osteoporosis. So it is history of previous fracture that make it a severe osteoporosis. Okay? The WHO came up with fracture risk assessment tool called FRAX. So they basically ask these questions and the patient answers yes or no, right? To all this stuff. You check it and you give a score, and then you bring a table, and that table gives you what the 10-year risk is of a hip fracture in that patient. It's a way of risk stratifying patients with osteoporosis. In other words, you have a group of patients with osteoporosis, and you want to, maybe you're in a resource poor environment, and you have to decide, because you can't treat everybody, you have to now decide who should you treat. WHO came up with FRAX. I've never used it. I don't use it because it's useless. If somebody has osteoporosis, why won't I treat it? Tell me. What do we need to treat osteoporosis? Calcium or vitamin D. It's not like we need gold. Why do I need to decide who to treat? Why? Does it make sense to you? Is calcium that expensive? Is vitamin D that expensive? Why do we need to choose who to treat? Why do we have to wait for high risk to treat it? You understand what I'm saying? It does not make sense. But you know, when you know people, you can come up with stupid stuff and everybody will say, clap for them. That is a major breakthrough. The next thing they're giving Nobel Prize. Like Trump wanted Nobel Prize, for Christ's sake. You see how easy you can get a Nobel Prize? Just cause trouble in some place and fix it too. Right? So basically, I'm giving you this because it's out there and somebody might ask you about it, okay? So it's called FRAX. So it's a risk assessment. Risk stratification, okay? Tool. And this is how you use it. You do it, it's high, you treat it. If it's intermediate, actually there was a presentation I was listening to a few years ago, and this guy was trying to make a case for FRAX tool. And basically he's saying that, well, maybe it's not really to risk stratify the patient. Maybe it's a way of helping us cut costs in deciding who we should send for DEXA scan. Right? So you can use FRAX score if you don't have DEXA scan, right? You can use FRAX score to decide who should you fly out to go get a DEXA scan, or who should you appeal to some foundation to pay for their DEXA scan. That kind of makes sense, right? A little bit, but what is the point of it still? I would rather appeal to a foundation to pay for calcium and vitamin D, which is a lot cheaper in all of my high-risk patients. If they're not black, they're high-risk. Treat them all. And if they're mixed, they're not black. It's one drop rule, as far as osteoporosis is concerned. Okay? Because you see some very light-skinned African Americans, they call themselves African American, but look at their gene, like 60% European stuff. Does not matter if you're not like black. You're not black.
I'm black.
Okay. So that is what this is trying to say. So if the risk is intermediate, then maybe you should do bone mineral density and then reassess probability. And then if it is high, you treat it. If it is low, you leave it alone. I don't know. Do what you want, but that is what the Frasco is. How do we treat this? It's very simple. Nutritional supplements, calcium, vitamin D, omega fatty acid, CLA, which is conjugated linolenic acid, and phytoestrogens. What kind of supplements can help you? Replace hormones, testosterone. You can give growth hormones sometimes. There are these bisphosphonates and these selective estrogen receptor modulators, alendronate, risendronate, indondronate. The one that is used the most is this alendronate, right? And then raloxifene belongs in that group. All of them do one thing: they increase bone mass. And in people with severe osteoporosis that can't tolerate any of these SERMs and bisphosphonates, there are antibodies now and protein inhibitors like denosumab, and then inhibitors of these WNT signaling pathways. I told you what WNT is: wingless braided integration site. This is a pathway. You know what second messengers are, right? You know, you have a receptor, you have a nucleus, right? Information to get from the membrane to the nucleus for it to be acted upon requires the second messenger within the cytosol. WNT is one of those second messenger groups, right? It's called wingless related integration sites. All right, and then of course the most important thing is physical activity and increased muscle strength. And if you know somebody has a significant risk, make sure that you take precaution to prevent form. So a good example is somebody, say an 86-year-old woman comes to you with dizziness, and they have a history of osteoporosis. Now they're presenting with dizziness. Their fall risk is higher. So if that person lives on a third floor of a building that doesn't have an elevator, you want to ask, do you have a daughter or somebody you can go to without having to go up this stairs until this dizziness gets taken care of? You know, you do everything you need to do to prevent fall in that patient. And none of this is exclusive. You can combine them, right? You can combine hormones with bisphosphonates. You can combine hormones with physical activity. All of them needs to be together. So just remember that. And so it's bisphosphonate, it's physical activity, it's nutrition supplements, stuff like that. Okay? And again, you do everything you can to prevent it. You address the modifiable risk. Encourage people to stop smoking. Dietary counseling for calcium and vitamin D intake. Unfortunately, in the United States, most of our vitamin D comes from milk because we fortify milk with vitamin D. And most people of African descent have lactose intolerance, so they don't really drink milk. You know, so it's interesting, right? That the same group that have lactose intolerance have the lowest risk of osteoporosis. It's interesting. Right? So you have to encourage folks to take calcium and vitamin D, right? And then encourage weight-bearing exercise. Weight-bearing exercise. Weight-bearing exercise. Very important. It is the weight-bearing exercise that strengthens your bone. What are weight-bearing exercise? Is swimming a weight-bearing exercise? No. Is stationary cycling a weight-bearing exercise? No. Weight-bearing exercise is the one you do when you walk, you jog, or you run, you bear your own weight. Right? So extremely important. Somebody can be physically active and be at serious risk for osteoporosis because they're not doing weight-bearing exercises. You got that? Excellent. And then you monitor the bone mineral density and brass score and stuff like that. And you do 4 risk assessment. You're going to have geriatrics. Have you had geriatrics?
Yes.
Excellent. So did he talk about 4 risk assessments yet? But you still have
2 more.
there are 2 more. Okay. I'm sure he will talk about 4 risk assessment because you always have to do the risk of fall in elderly patients. Is the most important thing you can do for an elderly person that you see. Because most of them, they go out with a simple fall, they break a hip, and that's it. Once they fall, they break a hip, they never get up again, they die of PE, sepsis, all kind of crazy stuff happens once you can't get up again. So the most important thing you can do for elderly people, especially if they have made due diligence to come to you for a comprehensive annual physical exam, you must do a full risk assessment in the elderly frail. Okay? Very important. Okay, so, and then you screen women and all that. Over the age of 65 and men over the age of 70, you screen them. If you don't have access to DEXA scan, use FRAX. It's called to screen them for osteoporosis. Okay? Any question about osteoporosis? Pretty straightforward.
Is there any screening for men? Oh, it's with men.
Yeah, exactly.
I thought it was with
Everybody gets DEXA scan. Everybody get FRAX too if you don't have DEXA scan. Okay? So if, for instance, if you are interested in studying osteoporosis in Bangladesh, you can take your elective to Bangladesh and do FRAX score on everybody, right? And see, oh, 20% of Bangladesh people are going to break their hip in the next 10 years if we don't do something. That's publishable. And then you get the Nobel Prize. All right. Are we good? All right, so let's talk about osteomalacia. Osteomalacia is basically unmineralized matrix. Bone is made up of hydroxyapatite, right? Which is a complex of protein, calcium, put in some very crazy arrangement that gives you the strength of your bone, right? It's not just calcium, it's a matrix that is now loaded with calcium, right? So when we talk about osteomalacia, the matrix is there, but the calcium is missing. So the bone is behaving like a soft tissue, right? Because it is an unmineralized. So the name osteomalacia basically means softening of the bones due to impaired mineralization. Okay? What causes it? Calcium deficiency is the commonest cause. And a rare cause of it is phosphate deficiency. So I put the 2 here. I'm using this opportunity to review hypophosphatemia with you because there is no place in your curriculum where you study phosphate metabolism. None. So anywhere I find an opportunity to plug it in, I plug it. And I've done it here. All right. So osteomalacia is most commonly due to calcium deficiency. How do people get calcium deficiency? Vitamin D deficiency is the commonest cause of calcium deficiency. Right. So limited sun exposure, yeah. Low vitamin D intake, fat malabsorption, following chronic pancreatitis or small bowel disease like celiac disease, or bypass surgery. So all of that will give you vitamin D deficiency of the intake kind, right? So if you limited sun exposure, I'm trying to think, it's not every sun that you go and sit in that will give you vitamin D. If if you do that, you get sunburn before you get vitamin D. So it's the 10 o'clock sun. That one that is just gentle on the body, that doesn't burn your skin. That is the one that gives you vitamin D. And the skin is an amazing vitamin D factory when you expose it to that UV light in that 10 o'clock sun. Okay, you will be amazed how much vitamin D you can make in 1 hour exposure. I used to know the number, but it's a lot. Okay, so limited sun exposure, low vitamin D, fat malabsorption. You know all this, right? Chronic pancreatitis, and you know why you will lose vitamin D if you're malabsorbing fat, because vitamin D is a fat soluble vitamin like the A, D, E, and K. And if you're not absorbing the fat, that means you're losing it with the fat in the stool, right? So that's how you get that. And then the second level of vitamin D deficiency after intake is defective 25 hydroxylation, because vitamin D is taken in from the gut, ends up in the liver, where it is converted first to 25 hydroxy vitamin D. If you have liver disease and you cannot convert vitamin D to 25 hydroxy D, you're going to end up with vitamin D deficiency, right? And then if you're on anticonvulsants, especially the phenolphthalein that activate and accelerate vitamin D metabolism, they will break it down before you can get to the plasma, before you can get to the bone. So that is one way you can get vitamin D deficiency, chronic liver disease. And then finally, vitamin D, after it's converted to 25 hydroxy D in the liver, is still not active. It becomes active only after it is converted to 125 dihydroxy vitamin D by the kidneys. So the people that have chronic kidney disease will have vitamin D deficiency, and that is why you notice nephrologists will always put patients on calcium and vitamin D, right? Because of impaired activation of 25 hydroxy by 1 alpha hydroxylase, which is an enzyme in the kidney, which is really what PTH activates. You remember that, right? And then there are mineralization inhibitors like fluoride and aluminum. You know what these do? Aluminum does exactly what aluminum foil does. So when you have a lot of aluminum and fluoride, that's why fluoride toothpaste have issues, right? Because it's exposed to fluoride. What it does, it seals, it covers those fluoride and aluminum ions, they settle on the bones, just like the foil will do. And they prevent anything from going into the bone matrix. So the calcium is there, the enzymes are there, but this aluminum foil is over the bone. Okay, so that can give you, that is what mineralization inhibitors do. So you see osteomalacia is primarily the vitamin D problem, right? Now, hypophosphatemia is very rare, okay? How do people get it? Well, the commonest way to get it is from reduced intake. How do you not take in phosphate? It's in every food because you're taking this medication. Antacids, sucralfate, we use this for gastritis, right? Unfortunately, they also bind the phosphate and prevent it from getting absorbed, right? That is why in nephrology, pay attention, in nephrology, when you give calcium phosphate, okay, in nephrology, when you give calcium with milk, you're using it as a phosphate binder. When you give calcium in between meals, that is when you're using it as a supplement. Because almost always, calcium will bind phosphate and it will go out in the feces as calcium phosphate. And you know, kidney disease patients, one thing they also have is increased phosphate, right? That causes problem, the metastatic calcification. Remember the calcium phosphate program. So we always, nephrologists always try to lower the phosphate levels. And the only one way to do it, vitamin D and calcium. So you give calcium with the meal to bind the phosphate. But if you want to give calcium as a supplement, you have to give it in between meals. Okay? And if you don't know that, you will be wasting a lot of money and hurting a lot of patients. Because if you're taking vitamin, if you're taking calcium that is supposed to be supplement with meals, you're not going to get it. It will be acting as a phosphate binder. If you intend for it to be a supplement, you have to give it in between meals. Okay? And then output. Well, the commonest one is Fanconi syndrome. You know about Fanconi syndrome from hematology, right? You know about Fanconi's anemia, right? This one is not that one. This is kidney Fanconi's. There are two diseases that you need to know: Paget disease and Fanconi's. Okay, I'll talk about Paget later. But this Fanconi syndrome is not the one of the anemia. It's the one of the kidney. It's a proximal convoluted tubule dysfunction that results in renal phosphate wasting. Remember, it is in the proximal convoluted tubule that 75% to 90% of everything that is filtered in the glomerulus is reabsorbed, right? In Fanconi syndrome, that doesn't take place. So they have renal glycosuria. You've heard that before, right? When you leak sugar in your urine, even when you're not diabetic. You've heard about renal glycosuria before, right? Okay, yeah. So Fanconi syndrome is a proximal convoluted tubule dysfunction that results in renal phosphate wasting. So it's an increased output. And then there is this FGF23 mediated tumor-induced hypophosphatemia. When you have connective tissue tumors like osteosarcoma, all these sarcomas, and the hemangiopericytomas and mesenchymal tumors, they produce this FGF23. They are not, FGF23 is supposed to be produced by the bones, not soft tissue. Right? So you have, but when you have soft tissue tumors, like it's all sarcomas, they can produce FGF and create increase phosphate excretion. Okay, and then the kidneys will start wasting phosphate. Why do I think you need to know about phosphate? Because you must know when to suspect it. Okay, let me give you an example. Say somebody comes to you that they have suprapubic pain and you think they have cystitis. You tell your MA, give me a UA. And the MA returns and you tell, oh, it's positive for leukocytes and leukocyte esterase and WBCs and glucose. You're like, what? Glucose? But the patient does not have diabetes. That is your clue right there that this patient could have renal glycosuria. Well, renal glycosuria could come because they have low tubular maximum, but it could also be Fanconi syndrome. If we have a low tubular maximum, you know what tubular maximum is, right?
Yeah.
Tubular maximum is the serum level above which the threshold, the serum level or threshold above which the kidneys will not be able to reclaim everything that is filtered and needs to be reclaimed. For glucose, it's 200. Huh?
We give us 180 maybe.
180, 200. 180, 200. It's fine. 200 is what I have. No, but 180 sounds reasonable. What can I say? Right? But above, you know why I lean more towards 200? Because random of 200 is what we use to define diabetes, right? So 180, just put a range in your wheel. What do you do with it? If it is 180, then if somebody has 189 and they leak glucose in their urine, do they have diabetes? Are you with me? If somebody has random sugar of 189 and they leak glucose in their urine, if you use 180 as your threshold for tubular maximum for glucose, right? Technically speaking, you have to call them diabetic. But that's not what the guideline says, right? The guideline says random above 200 or A1C above 6.5. Right? You see why I lean towards 200? But I think you're right. This textbook is probably 180. But in practice, I don't use 180 because it creates a complication for me. I don't know how to interpret it. You understand what I'm saying? And you know, this is what the beauty of clinical medicine is people will give you facts, but how you deploy and use that information in practice, you have to decide. That's what they're called guidelines. They're not called clinical laws. They're guidelines. And I happen to be simple and straight. If it's going to cause complication, I'll look for a way of simplifying it and make sure nobody gets it. You have to figure out things for yourself, you know. So if 180 was what was given to you, probably that might be correct, because I've not even looked at that in a long time. Okay. But what I'm saying to you is that in Fanconi syndrome, you have proximal convoluted tubular dysfunction that does not allow the kidneys to reclaim things that needs to be reclaimed, and they get lost in the urine. Now, that patient now has glycosuria. You're thinking this could be renal glycosuria because they don't have diabetes, but that might be your only clue to Fanconi syndrome. Now, if you miss it and you don't look for Fanconi syndrome, and the way you look for Fanconi syndrome is to screen the urine for other things that are not routinely measured by the urine dipsticks, right? So you look for amino acids, look for proteins and stuff. If you find those, then the patient has Fanconi syndrome. If you miss that, what will happen? Your patient will become hypophosphatemic. And I've told you what happens when you lose phosphate and you drop phosphate in your serum. Phosphate is important for energy transaction in the body. The body saves energy by converting ADP to ATP. The body spends energy by converting ATP to ADP. Both of those reactions require inorganic phosphate. If you don't have enough inorganic phosphate on board, the body cannot do energy transaction. If the body cannot do energy transaction, the body can function. Membranes can maintain their integrity. Things that need to move can move. Sperm cells can move. Ovulation can take place. These are energy-dependent processes. And the deadly consequence is that the red cells begin to burst in circulation. So you get hemoglobinemia, hemoglobinuria, acute tubular necrosis, acute renal failure. And your patient, you will not even have the chance to see that patient again. If that were done. Okay. So that's why I keep talking about this. All right. So how does osteomalacia present? This is something that we all remember, right? So in children, when they're growing, you see the something can give you these knock knees or bow legs, right? It can give you kyphosis. One major difference between osteomalacia and osteoporosis is that osteomalacia is painful. Okay, very important. Bone pain and tenderness. Okay? And in children, you can see those deformities. You know about the rickety rosary, right? Good. Yes, yeah, Arises grew, hypocalcemia and all that stuff. Okay. I saw this thing right here, and I think it's really cool. So, because when you are thinking that somebody has a bone mineralization disorder, one of the things you will do really is look at the serum calcium, phosphate, 25 hydroxy, and 125 hydroxy D. And you might measure PTH and alkaline phosphatase. So this table tells you how those play out with the different diseases. So I'm going to focus on the vitamin D and the hypophosphatemia. We don't worry much about everything else except this oncogenic osteomalacia. Okay. Now look at vitamin D. When you have vitamin D deficiency, of course, calcium is low, right? Calcium is low, phosphate will be low, right? And because it's a vitamin D deficiency, 25 hydroxy D will be low, right? Because this is formed from calcium. And because you don't have 25 hydroxy D, 125 hydroxy D will be low, right? And because the bones, PTH is going to be screaming because it needs to get, remember PTH responds to serum calcium, right? Ionized calcium. So because calcium is low, PTH is going to be screaming, right? So PTH will be high. And where does PTH work? It works on the bone. It spins the bone into serious metabolic activity, trying to get calcium from it to keep serum calcium normal. So alkaline phosphatase as a reflection of metabolic activities in the bone will be elevated. So you see that. I need you to understand why each of these is the way it is, so you can figure it out. Okay? Now look at liver disease. In liver disease, calcium is low because it's not being absorbed, right? Phosphate is low for the same reason. And you see, 25-hydroxy is low. And because 25-hydroxy is low, this is also low, right? PTH and everything else is high, right? Now, do you see that there isn't a lot of difference between straightforward vitamin D deficiency and liver disease and renal disease, right? The only difference is that in renal disease, 25-hydroxy is normal. That is what tells you the liver is fine. A normal 25D tells you this is likely to be kidney disease. You got it? And then you have all these other stuff that are very rare, vitamin D resistance and all that. That this one, you can look at it if you want, but don't worry about that. And then hypophosphatemia is very rare. Yes?
Sorry, I didn't catch that.
Yeah, because remember, 25D is the substrate for 125, right? So if you have normal liver, 25D will be normal, right? So I was saying that in somebody with osteomalacia, a normal vitamin D clears the liver and implicates the kidneys. You got it? Okay. And then hypophosphatemia, you see, in hypophosphatemia, everything is fine. Phosphate is low. In all kind of hypophosphatemia. Everything else is normal or high. Phosphate is low. So a low phosphate tells you that this is, whenever you see osteomalacia and serum phosphate is low, that tells you this is more likely a hypophosphatemic case. You understand what I'm saying? So everything else in hypophosphatemia is normal. Calcium, but phosphate, 125D, 25D is normal, but phosphate is always low. You got it? Okay. And then the toxicity, you see everything is normal. So you see somebody with osteomalacia, and you do the test and everything is normal, they are being poisoned. Either by the fluoride in their toothpaste, something, aluminum, something. Because all kind of supplements come into this country now from India and China, and people don't even know what they're taking, all in the name of supplements. People take a lot of poisons. Okay, so whenever you see osteomalacia and you do your test and everything is normal, that is your clue right there that this could be a toxicity. Okay? And then look at oncogenic osteomalacia. Oncogenic osteomalacia. This is because of ectopic production of FGF23. Remember that, right? You get low calcium, low phosphate. 25-hydroxy is normal, but 125D is low. All right? That one is what I want you to pay attention to. Most importantly is what your pattern looks like up here and down here. How does osteomalacia look on x-rays? They have some very interesting x-rays. You see the diffuse demineralization. Compare this x-ray to what you find in osteopetrosis, where the bone is so bright and looking like marble. You see how the bone is looking dark here? Right? Because under normal circumstances, about a third of the bone should be cortices, right? See how brittle everything looks here. And then you get these losers zone. Losers zone, right? Not losers, and the guys are losers, right? The guys, right? So, right there. So you see these loser zones that are actually partial transverse lucencies through this specific bone. If you're looking for loser bone, you look in the pubic rami, lateral scapula, in the ribs, in the medial proximal femur, and the posterior proximal ulna. Right? It is named after the Swiss surgeon Emil Loser. Right? They are also known as cortical infractions. The reason they are called cortical infractions is because they are usually at right angles to the involved cortex. See, if you look at the involved cortex, that loser zone will get almost at right angle to it, perpendicular to it. Okay, they are also called milkman lines because they were usually associated with because people that didn't drink milk were at risk for vitamin D deficiency because apart from fish, oily fish actually, and milk, those are the natural sources of vitamin D for this country. You can also see now, one important thing I need to know is that milkman lines or loser zones are not pathognomonic of osteomalacia. You can see them in Paget's disease, you can see them in renal osteodystrophies. Okay, so they are not seen only in osteomalacia. You can also see it in osteogenesis imperfecta. You heard about osteogenesis imperfecta? Yeah. Excellent, good. And then they are also known, loser zones are also known as insufficiency fractures or pseudo fractures, stress fractures, all kind of names for them. But the one they are known by the most, the one I preferred that you go with is loser zone because we have to remember Emil loser. Okay. And how do you see it? When you finally, in your exam, they ask you, how do you diagnose osteomalacia? You have to do bone biopsy. Really, that's how you diagnose it. But who does that? Who does bone biopsy? So that's why I said bone biopsy is the rarely required gold standard for the diagnosis of osteomalacia. So the gold standard for diagnosis is bone biopsy, but we don't do it because you don't need it. A 7-year-old kid comes into the clinic from Burundi looking like this, right? And mom has brought the kid in. It looks like that because the kid is having bone pain. How do you move more than you do the x-ray and you see loser zone? You need to go stick a needle in the kid's bone for biopsy. I mean, just give the guy vitamin D for Christ's sake. Right? You know, so in the textbooks, yeah, you need this and you're looking for reduced mineralization, right? And the softening of the bone, right? Now, whenever you diagnose osteomalacia, you want to make sure you're not missing osteoporosis, especially in an adult, right? And I put it here. In osteoporosis, everything is normal. Alkaline phosphatase might be slightly elevated, but osteoporosis does not have any laboratory abnormalities. It does not. It does not have any pain. It doesn't have any parameters on the lab that is abnormal. Osteoporosis is loss of bone mass with bony architectural deterioration. The problem in osteoporosis is in the bone architecture. It's painless, no lab abnormalities. Very important that you remember that. Calcium is normal, phosphate is normal, parathyroid level is normal. Alkaline phosphatase is usually normal. The second part of it that you must remember, whenever you diagnose osteomalacia, you make sure you're not missing osteitis fibrosa cystica. You remember what that is? Osteitis fibrosa cystica, when we're talking about hyperparathyroidism? You don't remember? Okay, it's there, go check it. Because osteitis fibrosa cystica is a clinical manifestation of severe hyperparathyroidism. Remember what PTH does, right? It goes to the bone and releases calcium from the bone. When hyperparathyroidism goes on for a long time, there is little or no calcium left in the bone, and the soft tissue left in the bone begins to take cystic shapes. That is what is called osteitis fibrosa. The fibrosa is the fibrous tissue that is supposed to be part of the matrix. The fibrous tissue that was supposed to get calcium deposited so it can form bone. But because of severe hyperparathyroidism, it's taking all the calcium away from the bone, and the fibrous tissue are now forming cysts. So it is called osteitis because of the inflammation of the bone. Fibrosa cystica. So you begin to form fibrous cysts in the bone. It is a clinical manifestation of severe hyperparathyroidism. It is characterized by loss of bone mass plus replacement of calcified bony architecture with fibrous tissue, formation of cyst-like brown tumors in the bone. It is associated with bone pains, kidney stones, and lab abnormalities. This is not what you have in your note. I was looking at it, I'm like, why does it have abnormal calcium level? That is so non-specific. The truth is calcium is elevated, right? Because it's an hyperparathyroidism, right? You remember the bone groans and the bones? Yeah. So this is what happens in the bones when you ignore the bone, the groans and the moans and the stuff like that of hyperparathyroidism. Okay? It's an important, significant differential diagnosis of osteomalacia. Why? Because it's another bone disease that causes pain, like osteomalacia. And when you see it in an adult, pay attention. You may not be simple osteomalacia. Why is that important? Because if you miss it, you will diagnose osteitis fibrosis cystica as osteomalacia. What is the commonest cause of hyperparathyroidism? What is the commonest cause of hyperparathyroidism? Hyper. It's an adenoma, right? Hyperparathyroidism is usually due to an adenoma, right? So if you misdiagnose osteomalacia, you misdiagnose osteitis fibrosis cystica as osteomalacia, you will send the patient with parathyroid tumor home on vitamin D. You understand what I'm saying? Right. That is why I put it here as an important differential diagnosis. Okay? You can't miss it. It looks like osteomalacia, but there's a tumor behind it. Because osteomalacia is so easy to treat. It's vitamin D you need with calcium. And there are two types of vitamin D. There is vitamin D2 and there is vitamin D3. Vitamin D2 is of plant origin and less effective. Vitamin D3 is of animal origin and is more effective. So it is not true that all you need is vitamin D. It does not matter whether it's plant or animal based. That is not true. Vitamin D of animal origin is more effective than vitamin D of plant origin. How do you remember which one is D2, which one is D3? Just remember, plants were on the planet before humans. Right? So D2 is plant. Okay? And D3 is animal origin, right? Plants were here before animals. And that is a fact. I don't know if that was why they call it D2 and D3. Like what we did doing that. All right. Any questions? Are you with me? See, this is an easy class, right? Okay. There's no question. I'm going to go for another 15 minutes and then I'll give you a break. Okay? So let's talk about Paget disease. So Paget disease, again, whenever you're talking about Paget disease, you have to be clear and be very specific because there is Paget disease of the breast and there is Paget disease of the bone. Have you heard about Paget disease of the breast before? No?
Yes.
Yes. You never heard about it before. Paget disease of the breast. Paget disease of the breast. The reason it's important is because you will see a woman sometimes who will come to you with a rash around the nipple that looks like eczema. And if you're not aware of Paget disease, you'll be giving them antifungal cream when you should be doing mammography, biopsy, and maybe taking out that breast, because that is a very sneaky presentation of invasive ductal carcinoma. Under normal circumstances, you expect a ductal carcinoma to cause breast pain, bloody nipple discharge. That's what you will expect. But sometimes it will not give you nipple discharge. It may not even give you pain. It will present like a scaly rash around the nipple. That's redness, scaly, flaky nipple skin lesion that is driven by an invasive ductal carcinoma of the breast. It's called Paget's disease because we want to talk about it in its own category to give you the awareness so that you don't just gloss it over and give the person clotrimazole because you think it's eczema. No. My grandmother can do that. You can't. Now, Paget disease of bone is a very interesting condition, right? Because this is what normal bones look like, right? You see, spongy, well, you all eat chicken, right? Drumstick. When you eat drumstick, when you're trying to chew, and I know Americans don't eat bones, right? But they say dogs eat bones. In Africa, we eat bones. When I remember this cartoon I read a long time ago. There was this guy from England visiting Africa, and he went to a restaurant, and in the restaurant he saw all these Africans eating the bone, because that is the stuff you try to get to the marrow, suck out the liquid. It has a different flavor to it. And then the guy looked at him and went, "You guys eat bones?" And then they look at me, "Yeah, that is the real deal." He said, "No, in England we give the bones to the dogs." And like, well, in Africa we give the meat to the dog. You know, but why am I telling you that? If you remember when you're eating the bone in the drumstick, the top of it is soft compared to the shaft of it, right? That soft, yeah, because you don't eat it, you don't know. Try it next time you eat drumstick. Right? That soft part of it is soft because it's porous. It is exactly the way the human bone is like. In the top part is porous and spongy. It's called spongy bone, right? Whereas when you now have pattern, and then in the cortex, you have this strong bone, right? And the marrow is right there. And the normal bone is compact in the cortex and porous toward the end. And in the middle right there is where you have your bone marrow, where your red cells are formed. See what happens in Paget disease. Paget disease, the bone is totally disorganized. The bone is bigger in mass, but especially in the weight-bearing area, it's totally disorganized. And because it is not well laid down, it does not retain strength. It behaves like osteomalacia, except that they have nothing to do with vitamin D deficiency. We'll talk more about it. So, Paget disease of bone, believe it or not, this woman actually existed because this picture was painted by Quentin Matisses in 1513 of this duchess that did in fact exist. And she was a woman, and she had a red rose. A red rose in the hand of a woman was the way women proposed to men in ancient in England, right? So she had to hold this red rose. We never knew if anybody came for her, but she had the rose. Right? They didn't know why she was so ugly. It turns out that later on, when we got to know about Paget disease, and people started finding out what was going on, somebody dug her portrait out and said, "Oh my goodness, that was what she had." It was Paget disease. Paget disease can be very disfiguring. Look at her frontal head. These are headdress. These are not horns, okay? These are headdress. She's also poor, right? So, what is this disease that can disfigure a man like this? It's also known, because it can disfigure you like this, we call it osteitis deformans. So it's a disfiguring inflammation of the bone. Right? It's called osteitis deformans. It is characterized, this is the key, it is characterized by an initial excessive bone resorption followed by a compensatory but chaotic bone formation. So let me tell you what happens in Paget disease. I'll paint a picture for you. Under normal circumstances, right, you decide to remodel. No, let me just use the real story. In a normal bone is resorbed by the osteoclast, and the osteoblast come down right after them and lay a new bone in the right order. In Paget disease, something is wrong with that sequence. So the osteoclast come, resorb the bone, resorb the bone, resorb the bone, resorb the bone, and the osteoblast don't respond. So the bone stays there, resorbed. Then, after a while, it's like the osteoblast wake up. Say, whoa, 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 we need to do some work here. And then in a hurry, they start laying down the bone structure, but they lay it down in such chaotic manner, not in the lamellar. The normal bone structure is lamellar, right? They lay it down in so haphazard manner that instead of having a lamellar structure, you have this chaotic mesh that they put in place. So instead of having bone structures that look lamellar like this, you end up with bone structure that look like this. In a lamellar bone structure, they are able to bear weight better. In this mesh, this trabecular pattern, the bone is weak. And that is because the osteoblast did not come immediately after the osteoclast to lay down the bone. There was a delay. And then they come back in a hurry now, and now they're laying everything like so crazy. So that what you find in Paget disease is that it replaces the stronger linear lamellar pattern with weaker mosaic trabecular pattern, replacing stronger bony tissue with weaker fibrous connective tissue and increased vascular tissue. And because they are doing it in such a hurry and they're doing it chaotically, they need more blood supply than the bone can ordinarily have. So they get new blood vessel formation, right? And because these blood vessels are weak and they are new, they don't have the necessary capillary network that is supposed to connect the arteries to the veins. Under normal circumstances, arteries bring blood, the capillaries slow it down for the cells to take what they need, and then they gather into venules and return into the veins. In this Paget disease, the arteries are formed in a hurry. The capillary bed did not have time to develop, so the blood flows from the artery, boom, right through very minimal capillary bed into the vein, and it forms an AV malformation. That is the reason Paget disease is a cause of high output failure. Remember in cardiology? Right. Because it shunts blood from the arterial side straight to the venous side, because there isn't enough sufficient capillary bed to slow it down and do the normal transfer. So in Paget disease, they behave like high output failure, like AV malformation type of patients, right, in the cardiovascular system, right? Okay. Why do we have to diagnose it? Because it makes people ugly and they don't like it. But more importantly, it predisposes to osteogenic sarcoma, bone cancer. Okay? So again, what causes it? We don't know. All we know is that there seems to be some genetic predisposition. It runs in families. And not everybody that has a family history develops it. So it looks like it runs in families, but it needs some environmental precipitation. Something in the environment has to precipitate it. There is some people suggested that perhaps slow virus infection, like measles, mumps, all these paramyxoviruses, viruses, viruses have a way of messing with your DNA, right? So there is some suggestion that exposure to slow virus can be a problem. This is a cartoon that just tells you what I just explained to you. Osteoclasts come, resolve bone, and then all of a sudden the osteoblasts wake up and they start doing it very, like, intensely. And there is a point they get and they burn out. So they can't lay anymore and they leave the bone weak and brittle. Okay? How does the patient present? It's prominent in the skull. So that's why you saw that patient has like frontal bossing, right? Like she has sickle cell disease. In the spine and in the long bones. They have bone pains and deformity and joint pains. Now, did you notice what it does to the bone? Right? It deforms the bone. Right? That's what it does. At the base of the skull, there are holes through which cranial nerves and blood vessels exit. So when the bones are deformed, those tiny holes through which those veins and nerves come through get compressed. Right? So an exit in the skull that is supposed to look nice, round and smooth, now looks like this. Because the bone is deformed. So have all this complicated presentation, deafness when the labyrinth is involved, blindness when the optic nerve is compressed, loose teeth because the jaw that holds the teeth is not stable and strong. Then you have heart failure, I explained that to you. And then you have kidney stones as well. And then you do their blood test, what do you see? They get hypercalcemia. But you know what's interesting? The hypercalcemia is more obvious when you put them on bed rest. As long as they're up and about, they are not hypercalcemic. That is the reason you will notice if you look in some textbooks and you're looking for causes of hypercalcemia, some people will include Paget's, others will not. Because not many people understand that in Paget's, the hypercalcemia is mobility dependent. If you're mobile, you don't get hypercalcemia. It's when you admit them and put them on bed rest, or when they get hospitalized for a condition that keeps them in bed for more than 6 weeks, you will see hypercalcemia. Then they will start having kidney stones. You got that? So very important. Then, of course, because of the intense metabolic activities in the bone, they get elevated alkaline phosphatase. But guess what? The calcium is usually normal, and phosphate is usually normal. The liver enzymes are usually normal. Unless they are immobilized, then the calcium will be elevated. Anytime you suspect that a patient has Paget disease, you have to look for these things called markers of bone turnover, because Paget disease is a bone turnover disease, right? So you get elevated hydroxyproline in the serum and pyridinoline in the urine. So urinary pyridinoline and serum hydroxyproline are things that you will use that will further support the diagnosis of Paget disease. Okay? See how it looks. Look at Paget disease. Osteolytic lesion in the frontal bone. You can get this cutting wool appearance. And you can get this hybrid vertebrae. These are all radiographic manifestations of Paget disease. So radiologists can give you any one of these depending on which X-ray you send for. Okay? Of all of them, the cutting wool appearance is pathognomonic. Because you can get ivory vertebra in another. What else can you, in which other bone disorder can you get this?
Or
Osteopetrosis, right? The marble bone disease. It could be just like that, right? And this osteoporosis circumscriptor, I just said localized osteoporosis, right? It's not pathognomonic. Of all of them, this cutting wool appearance is what is pathognomonic of Paget disease. How do you treat it? It's so simple. Healthy diet, active living, keep them moving. You can give bisphosphonate or calcitonin analogs, but invariably they might need surgical intervention because they do fracture the bones. The bones do get deformed and they do compress nerves. Right? And I'm giving you examples of some of the bisphosphonates, their dosages. You should know about this: pamidronate, Actonel, rosidronate, Skilate, Didronel, Reclast, Fosamax is very popular. Alendronate was one of the first ones that came out. The dosages, this one is not important. When you get your pharmacopoeia or the software on your phone, all you need to do is type in bisphosphonate, and it'll give you options, cost, and you can decide what you want. You just, I have this space, and you know what to do with it, so I put it there. All right. You want to prevent Paget disease as much as you can. So whenever you see Paget disease, you diagnose it. You know he has a genetic predisposition. So you want to screen the siblings and children of patients with Paget disease. And it's a very simple screening test. Alkaline phosphatase. Elevated alkaline phosphatase in them tells you it's already started. So you can start treating it, and you can save their hearing, you can save their sight before they become complicated like that. You just screen with alkaline phosphatase. And then I put this here to let you know that alkaline phosphatase is an enzyme in the blood, right? It's part of liver panel, right? But the enzyme itself comes from many places, but basically it comes from the liver, the biliary tract, and the bones, right? Some quantity in intestinal mucosa, and when people are pregnant, they can exhibit a little elevation, right? So, whenever you see elevated alkaline phosphatase, you must check the liver, right? Because you can see it in hepatic tumors, hepatotoxic drugs. When we give people statins, alkaline phosphatase can go, right? And Quest is not a good lab, but we're stuck with them because they're the biggest. You know, they're like Edison's in the South, right? We just have to take whatever they give us. Under normal circumstances, right? When you see elevated alkaline phosphatase that you cannot easily explain, you're supposed to send to the lab for them to do the fractionation. Because even though alkaline phosphatase comes from the bone to the liver and sometimes from the gut, you can fractionate it and tell which proportion is from the liver, which proportion is from the bone. Right? But all the alkaline phosphatase fractionation that I have ordered since I have known Quest, they always come back crazy. Right? So somebody, for instance, might have alkaline phosphatase that is supposed, under those circumstances, I think it's supposed to be less than 120. Say they have alkaline phosphatase 300, right? And you're like, oh, will you fractionate it for me? And then the same thing, the fractionated result, they say bone 60, liver 40. I want to stupid result it is. Those one is 300. I can bone and liver together be less than 100. Where is the rest? So at the end of the day, you don't know what to do with it, so I stopped ordering it. But when I was across the street in County, when they fractionate it for you, it will come out like bone 200, liver 60, gut 20. So it makes sense. So you know where the problem is and you know where to focus. But Quest, I don't think they know what they're doing as far as that is concerned. So, again, you can see that, like I told you, alkaline phosphatase 1 is of liver origin. This is just information. What I want to tell you on this slide is that you screen for it. Anytime you diagnose it, you screen for it in the siblings and children of patients with Parkinson's disease. Okay? All right, I think I'll give you a break now. And then we'll finish when you come back. 5 minutes break. Okay, all right. 25 hydroxy is normal, so that means there is no liver disease, right? 125 is high because it is stimulated by PTH. So what do you think case number 1 is? Exactly, primary hyperparathyroidism, right? Now let's take a look at the case number 2. Everything is fine. Osteoporosis, right? Good. Case number 3 and case number 4, they are exactly the same thing, except that in case number 3, 25 hydroxy is normal, whereas it is low in 4. So can you tell me what that is about? Thank you. Thank you. So 4 is oncogenic osteomalacia, right? And 3 is regular osteomalacia. You got that? Excellent. What about 5? Everything is okay except alkaline phosphatase. Ali.
So it would be osteoporosis.
Exactly. That would be osteoporosis. And what is the 6th case? A renal osteodystrophy. And the way you know that is, look, PTH is high, calcium is low. So that means this PTH is high because calcium is low. Right? And then phosphate is high, oh, then something's wrong with the kidneys. If that is true, 125 will be low as well because that means the body can't make 125. You see that?
But you wouldn't put Paget's disease on there with osteoporosis.
No.
It would show the same.
Exactly. Paget disease, you figure out from patient's presentation. So somebody, if I want to give you if I was to test you on Paget disease, I will paint you a picture of a 68-year-old male with deafness on the right side. And I will make it a nerve deafness. I will give you a picture of nerve deafness, and when you do the labs, I will give you elevated calcium. Right? And then you have to, and then I'll put under the DF system, he admits to pain in the hip and his bones over the years. He doesn't know what it is. Right? So that will be where I'll paint a picture for you. I think anybody will paint a picture for you. Right? You got that?
So for the 3 and 4, except the 25, I thought it's switched. The number one is supposed to be
The one that is 3 is the oncogenic, the one with the.
So number 3 should be D.
Number 3 is D, number 4 is C. Yeah,
You said it wrong.
You said it wrong?
Yeah.
Oh, sorry. Okay, anyway, that is it now. All right, so I'm going to switch gear in a minute, but I think I don't know why Stephanie is taking longer than I expect. I'll be right back.